Hello everyone, and welcome to this lecture about fluid loss and also an introduction to hypovolemic shock. The objectives of this lecture are to discuss some common causes of fluid loss. I'm going to give you an introduction to hypovolemic shock, the signs and symptoms of hypovolemic shock, and the nursing care of a patient with fluid loss or hypovolemic shock. We'll also look at some treatment options. So when we're talking about fluid loss, we're talking about a loss of volume in the intravascular space. And this can be either due to blood loss, so if someone is vomiting blood, for example, or they've lost some blood through trauma or surgery, or it can be related to fluid loss. So we can lose fluid by having severe bouts of diarrhea or vomiting. We can pass too much urine. So in DKA, for example, diabetic ketoacidosis. And also if there's some damage to our skin. So burns in particular come to mind because if our skin is burnt, fluid escapes our bodies because the skin no longer protects it. So we have lots of fluid leakage when we have burns to the skin. There's also this condition called third spacing. An example of this is when fluid moves to a different space, but it's not in the intravascular system. So a very common example that you will see in an acute setting is ascites, and that's due to hypoalbuminemia. So here is a picture of what ascites looks like, and you have this collection of fluid here in the belly. Okay. The reason why this happens is because usually it's related to liver failure, and if the liver is producing less albumin, there'll be less albumin in the blood. Okay, and this albumin actually maintains our intravascular volume. So if there's less albumin floating around in the blood, it causes fluid to leak into the tissues. Okay, and a common site for the fluid to leak into the tissues with liver failure is in the abdomen. So as you can see in this image, this cross-section image, there's all this fluid here that just collects. And even though there's a lot of fluid here, the patient will still be intravascularly dry, so they will be dehydrated. But it's very important to drain this fluid, so we can use a pigtail drain to drain the fluid from the belly using gravity, and this will offer more comfort for your patient because it's quite uncomfortable. So massive fluid loss from either blood or fluid leads to hypovolemic shock. Okay, so hypo means low, volemic means volume of blood. So hypovolemic shock is low volume in the blood. Okay, so ordinarily your heart delivers oxygen and nutrients to the vital organs and tissues through the arterial system. Okay, and it returns back to the heart via the venous system. This is very simple. So in hypovolemic shock, there is low volume in the vascular space here. Okay. This low volume coming back to the heart reduces preload, which is essentially filling of the heart. So if the heart is not filled as much, this is actually going to reduce cardiac output. Okay? So this is going to reduce the amount of oxygen and nutrients delivered to the tissues and the organs. Okay? So remember the simple equation that MAP equals cardiac output times systemic vascular resistance. MAP is mean arterial pressure. Okay, so this is your blood pressure, your average blood pressure, which you will learn more about when we discuss shock in more detail. Okay, but in order to get this blood pressure, this mean arterial pressure, we multiply the cardiac output times systemic vascular resistance. Okay, so if we have a decrease in the cardiac output, we need to have an increase in systemic vascular resistance to increase our mean arterial pressure. I know this is a lot to get your head around, but I'll try and make this as simple as possible. So when the baroreceptors in our bodies detect a drop in blood pressure, so a drop in the mean arterial pressure, the sympathetic nervous system releases adrenaline. This leads to vasoconstriction. Okay, so we're looking at the venous system here, and what happens is these tubes are squeezed essentially to try and increase systemic vascular resistance and increase preload to the heart. Then this will increase cardiac output and blood flow to the organs is restored. This release of adrenaline will display the following symptoms in our patients. So a typical patient suffering from hypovolemic shock will have an increased heart rate or tachycardia, and also will have an increased respiratory rate as the body attempts to bring in more oxygen to the tissues. Okay. They will also have a low blood pressure, and that's because the volume in the blood has dropped. Okay. They will also be cool, clammy and pale, and that's due to the release of adrenaline and peripheral vasoconstriction. So all the smaller tubes in our peripheries, they all squeeze to divert the blood to our vital organs to keep us alive. And that is why your patient will feel cool, they may be clammy, and they will certainly look pale as there's reduced blood flow to that area. They will also have dry mucous membranes because they're intravascularly dry, and a decreased urine output, which is due to the reduced blood flow to the kidneys. So hypovolemic shock is generally diagnosed based on the patient's history and observations, but there are some useful blood tests that can help paint a more detailed picture of what's going on inside the body. Arterial blood gases, ABGs, they can give us a lot of information about oxygen and carbon dioxide levels, and they can also tell us what the serum lactate is. Now this is specific for identifying if there's any low tissue oxygenation, which is a classic sign of hypovolemic shock. Okay, we can also do a full blood count, and within the full blood count we can find out what the hemoglobin is, So if there's a low level of hemoglobin, that's related to blood loss. And they can also test the hematocrit, which identifies the total amount of red blood cells in the body. And obviously this will be decreased if somebody is in hypovolemic shock from blood loss. So the treatment options for hypovolemic shock, obviously it depends on the cause. So what actually caused this in the first place? We need to replace the fluids or the blood if that's what's been lost. Also, the fluid loss needs to be stopped. So if the patient is actively bleeding, you would stop the bleeding and replace that volume. We may also need to support our patient's blood pressure with vasopressors initially to maintain a blood pressure. So as we discussed earlier, our body releases adrenaline to help increase systemic vascular resistance, thereby increasing blood pressure. We can mimic that with artificial adrenaline or noradrenaline that we can give our patients to mimic the effect that adrenaline does within our body. And that's often a temporary measure to maintain blood pressure and keep the patient alive until we can get some fluids or blood into them and fix the cause. If the patient has lost a massive amount of blood, they may also need a blood transfusion, platelets, and coagulation factors, and this would be given through fresh frozen plasma or FFP. And as we discussed when we had the patient with ascites, if the blood albumin levels are low, we can give them albumin intravascularly, and this will prevent any third spacing. So fluid will be maintained in the intravascular space. Now it's very common to look after patients with hypovolemic shock in the acute setting, whether it be in the ward environment, in the emergency department, or in a HDU, ICU area, even on cancer wards as well. So you will come across a patient in hypovolemic shock at some time during your career. And their treatment depends on where they are. So obviously when we're looking after our patients, these patients can become very, very sick very, very quickly. So we need to do an A to E assessment on our patient. And we should increase the frequency of observations, paying close attention to their ADS score, and act on this accordingly. If the ADS score is if the ADS score is increasing, we need to let the doctor know and call a met call if need be. So the patient will obviously need filling with fluids or blood, so it's really important to have 2 large bore IV cannulas in place. And that may be something that the doctor would do unless you are trained when you are postgrad. The patient will also need cardiac monitoring as well, and medications and fluid administered as charted. And if your patient is deteriorating quite rapidly, you can be very busy putting up a lot of fluids, albumin, blood. So it's really important to reassure your patient at this stage as well. If they're sick, they're going to be quite anxious and scared. So always remember, even though you are busy, you run off your feet, just reassure the patient, hold the hand and talk them through everything that's happening. And if need be, do not be scared to escalate the care. If you're on a ward environment, the doctors may want to escalate the care of the patient to the ICU environment for closer monitoring. We can also position our patient as well to try and increase the blood flow to the vital organs. And the recommended position when it comes to hypovolemic shock is the modified Trendelenburg. Okay, and this is where we'd raise the legs of the bed up. So as you can see, gravity will just help push fluid towards the heart and the brain. And always make sure that your patient is comfortable in this position. And that wraps up our lecture on fluid loss and introduction to hypovolemic shock. And here's a list of references if you'd like to find out more information. Thank you.